We are live.
Good evening, all. Welcome to iFocus Online, the 384th episode, 59th in the Oculoplasty module. Today, we have with us the Master Examiner himself, Dr. Honavar from Center for Sight, Hyderabad, to not only orient all of us, but also to instill a lot of confidence with this exam special, the Objectively Structured Clinical Exam, OSCE in Oculoplastics. Over to you, sir.
Thank you, Subha. I'll share my screen. Are there any external participants? Did you share the links with anybody? No.
We have shared it on the group, though.
Okay. All right. Great. No problem.
Yeah.
So we'll limit to whoever has logged in then. That's 4 of you. All right. So this is going to be very simple. This is, exam style, probably DNB style, and may also be useful for AIOS FACO. But at the same time, this could be used for any exam pattern. Some of the universities have OSCE as part of their exam, some don't. But irrespective of that, it's a learning exercise. So the first question, I think Subha wants to take it. Right. So looking at this lady, forget about the small lesion in the left lower lid. I'm not asking any question about that. But what do you think is happening? Forget about this one. We're not bothered. Yeah. Just tell us about the right eye lower lid. What do you think is the condition?
From the photograph, it appears to be that she is a elderly individual, and there is a entropion or interning of the lower lid margin with the lash to corneal touch.
Hmm. What do you
Uh,
think is the etiology looking at this?
uh, Senile entropion.
Okay. And mechanism?
One is overriding of the preseptal orbicularis over the pretarsal orbicularis,
Mm-hmm.
and
The questions would be like this. Diagnosis, of course, you already said it is involutional entropion. If you say that in 2 words, then there is no further questioning. Generally, OSCE is written, but sometimes it could be oral as well. Pathogenesis, I asked you about the mechanism. You already mentioned that there could be overriding of preseptal orbicularis over pretarsal orbicularis. So in a given situation, how do you know whether it is overriding or not? Is there any clinical test to say that?
um,
Quickly. Yeah, so some of these patients have entropion when they sit in front of you, some don't. If they have an entropion already like this, you can easily reverse it by pulling the lower lid down. All right. Then they will not immediately have entropion unless they have a spastic component. So there is a phase of rest, and only on further dynamic action on part of the patient will entropion occur. Okay, so now ask the patient to look down without squeezing. And when the patient looks down, if entropion manifests, that is most likely because of overriding. Then you ask the patient to look up. The entropion snaps back or reverses. So if it is pure overriding, when the patient looks down, entropion manifests. When the patient looks extreme up, it snaps back or becomes better. Or when the patient looks up, it doesn't happen. That is generally because of overriding. The second mechanism is, of course, dehiscence or disinsertion of the lower eyelid retractor, where you'll find lower lid lag, just like the upper lid lag. The lower lid fails to move along with the movement of the eyeball. So there is some amount of lag. There is deepening of the inferior fornix. And if it's a fair-skinned individual and you have a bright light, you may actually see a whitish line or a band somewhere close to the fornix, far away from the lower margin of the tarsus. In addition, the resting position of the lower eyelid, as you see in the left eye. So what is happening in the left eye? The resting position of the lower eyelid is
slightly.
higher, right? So that's mainly because of detachment of the lower lid retractor. That eye hasn't manifested with entropion yet, but at this point in time, but of course, she already has the detachment of the lower lid retractor. So these are the signs that the patient has lower lid retractor dehiscence or disinsertion, mostly disinsertion. The third mechanism is horizontal laxity of the eyelid. We'll talk about that later. Now, the next question is, what are the surgical principles?
Um, to address
Address the mechanism.
yes.
Yeah. Tell me.
In cases of overriding of the preseptal over the pretarsal, we create a scar in between the two, such that we prevent the mechanism from taking over. One. Um, for horizontal lid laxity, we address it by horizontal lid shortening procedures. Third, when we have a lower lid retractor dehiscence or disinsertion, depending on whatever it is, we tend to reattach back to the tarsus.
Okay. Name one classic surgery that addresses most of these mechanisms. Complete name.
Jones, Ree, and Warwick procedure.
Very good. So it's Jones, Ree, and Warwick procedure described in 1972. It's a very old procedure. It is, celebrated its 50th anniversary just a couple of years ago. But it's a very, very classic procedure. Nobody has done a better procedure than that so far. There are modifications. There are several modifications, including by Nakamura. But basically, nobody has kind of changed it so much, right? It's still in the way that it has been described. Suturing may be different, and the way the retractor is looked for is different, but final principle remains the same, and it addresses two of the three mechanisms. It reattaches or plicates the lower lid retractor. It also creates a plane of scarring between the preseptal and pretarsal orbicularis because your incision is at the lower border of the tarsus. If your incision is just under the eyelashes, then you may not be able to address it, although of course you may do the dissection, etc. But if your dissection or if your incision is right at the lower border of the tarsus, then it easily addresses this overriding because you suture it there. Orbicularis is also sutured there along with skin. It does not address horizontal laxity, which is not a shortcoming because the procedure was not designed for it. And if a patient does have horizontal laxity, you'll have to add another procedure, which could be lateral tarsal strip. So that completes the first OSCE. So I'll skip the video now. Okay. Who is going to take this next? Ruju. Ruju?
Yes, sir, it's a outturning of the lower lid. So basically a involutional ectropion.
Involutional ectropion. Why do you say it is involutional? Why can't it be cicatricial? She has some skin changes also on the medial side. No? Do you know the grades of ectropion?
Sir, mild is just outturning when the puncta, lower puncta is not well opposed to the globe. Grade 1 is when there is a outturning of the medial border of globe.
So read about it. We don't have time to discuss in detail. It's already been covered. But basically, they may ask you about the grading of entropion. And more importantly, they'll ask you about the types of lower eyelid ectropion. What are the types?
Involutional, cicatricial, paralytic,
and
mechanical.
Mechanical. And the last is this one. What is this?
Tarsal ectropion.
Tarsal ectropion. So there are 5 types of lower eyelid ectropion readily. Some of them may have mixed etiology. But what you said is correct. But you please add tarsal ectropion. That will get you brownie points. If you're very close to a medal, then you'll get it. If you add tarsal ectropion. The next question, of course, yeah. What are the clinical tests that you would do?
Sir, pinch test, snapback test, medial canthal laxity, lateral canthal laxity, distraction test, which includes both vertical and horizontal distraction test.
You said a lot of things. Can you very quickly explain?
So in pinch test, what we do is we measure the amount of lower lid which is pinchable. So the distance from the lower lid to globe, we measure. If it is more than 4, we can grade it as a
6 millimeter.
Then medial canthal laxity and lateral canthal laxity.
No,
So
but
usually
before that, do you have one more test?
Yes, a snapback test. So
Hmm.
in that we pull the lower lid downwards, and if it should ideally immediately go up. If it
You pull
doesn't,
the lower
then
lid down and release it, and then what should happen?
it should immediately go back to its original position.
Okay, snap back into its original position without the patient having to blink. When the patient blinks, it does snap back into original position. Right. So this is pinch test, more than 6 millimeters. Snapback is what you already saw. So what is the grading in snapback? Are you aware?
Sir, 2 second is mild, 2 to 4 is moderate, and more than 4 seconds is severe.
Yeah, so it is less than 2 seconds, 2 to 3 seconds, and 4 to 5 seconds. There are grades actually, grade 0 to 6. Immediate or less than 2 seconds is called grade 0. Grade 1 takes 2 to 3 seconds. Grade 2 takes 4 to 5 seconds. Natural progression. In eyelid, everything is 2 and more anyway. So grade 3 takes more than 5 seconds but returns to its normal position with blinking, as you saw in that patient in the video. And grade 4 never returns back to its normal position. And for pinch test, it is 6 millimeter. In fact, you should never get confused because some of the books mention snapback and pinch and distraction all together, or distraction and pinch together. But these are absolutely three different tests. In pinch test, the term that is used is distraction because you are actually pulling the lid away from the globe, right? Here you're doing vertical distraction. So pinch test, other name, technical name, correct name is vertical distraction test. Okay. Actual pinch was designed to assess the horizontal laxity of the lid itself. How much of the lid is lax? Suppose between your two fingers, if you're able to pinch, say 6 or 7 millimeter of tissue, correct? With the lid still being, rest of the lid still being opposed between the fingers, that means that that amount of tissue is excess. So you mark 2 points on either sides of it, and that is the amount you will excise to put the lid back into its normal tone, isn't it? So that is how you assess the pinch test. But this, somehow the name got converted to pinch test. It was the pinch way of assessing. In fact, you can use two forceps to pinch the lid and assess the amount of laxity based on which you decide how much to excise. But this is a nice table to remember. It also has medial and lateral distraction test. Medial distraction is for the lateral canthus and lateral distraction is for the medial canthus. Some of the residents actually tend to reverse it. But well, I mean, you can just go back to the video and take a screenshot of it. We don't have time to explain, but basically how much the laxity of the medial canthal tendon is indirectly demonstrated by the position of the punctum, how much the puncta can be moved laterally and how much the lateral canthus can be moved medially. Another clue to laxity of the lateral canthal tendon is, sorry, I think, yeah, my pen got disturbed. Yeah. Suppose this is the lateral canthal angle, which is absolutely sharp. If it becomes rounded, then that means that there is lateral canthal tendon dehiscence or disinsertion. Next is you always measure the distance between the medial limbus and the medial canthus and lateral limbus and lateral canthus. In Asian Indians, it is 2:3. If this ratio becomes almost 1:1 or more on the medial side, then you clinically decide that it is lateral canthal tendon laxity. So there are many tests to decide whether there is medial canthal tendon laxity or lateral canthal tendon laxity or both, so that you decide on the procedure. This is a very famous or a landmark article, medial distraction test, lateral distraction test for the medial canthal tendon, and also Olver, Jane Olver, who wrote the one of the standard books on lacrimal surgery. She describes horizontal resting position of the puncta itself. Where exactly is the puncta located when the patient is looking at primary position? Based on that, also, she has attempted to grade. This is a landmark article. If you have time, you can read it. It is published in a journal, Ophthalmology, about 20 years back. And she also has graded it depending on how far laterally can the puncta, lower puncta, be distracted. Depending on that, it can be graded. That amount of distraction, as you see in the picture, is very much possible in a given situation. So that amount of laxity would be there. And if a patient has medial canthal tendon laxity, you tend to fix it. You have to do a medial canthal tightening procedure, whereas if there is lateral canthal tendon laxity, you do a lateral tarsal strip. If there is global laxity, depending on how much relatively each of which is there, you can do a middle procedure where you exercise a pentagon of lid while fixing the medial and the lateral canthal tendon as it is. Now name a classic surgery for involutional variant of ectropion, lower limb. Just name.
Lateral tarsal strip.
Lateral tarsal strip is a very good answer. Otherwise, for paralytic entropion, they may ask in the same OSCE, the question may be paralytic entropion. Most of the examiners would want the answer as Kuhn-Zimmermann procedure, although it is not very commonly done. It's a very extensive procedure, but that is the answer they would expect for paralytic entropion. Okay. Next is, I think, Fanas. Yes.
Yes, sir.
Yeah.
So from the photograph,
Hmm.
it appears to be an elderly male, and both of the eyes show drooping of the upper lid.
Okay.
So it is bilateral ptosis. So it might be
Yeah, we don't know the etiology. It is bilateral ptosis. That's all we know. So what are the two differential diagnoses for a bilateral ptosis of this sort out of many? OSCE is always very, very specific. They ask 2, 3, or 4 based on that they distribute the marks. The questions are all there. You're not audible.
sorry, sir. One could be like involutional ptosis, and the other could be myasthenia gravis, or chronic progressive external
ophthalmoplegia. Right. So myogenic or involutional are the more common considerations in this situation. Name 2 clinical tests to investigation to confirm or rule out the etiologies.
To rule out myasthenia gravis, we can go ahead with the clinically, we can go ahead with the ISPAC test. And in case if it is like 1.5 mm or 2 mm, so in order to confirm, we can very well go ahead with a neostigmine test.
Okay. Or you just, first thing you could possibly say is look at the levator action. If levator action is good, it's unlikely to be myasthenia or even chronic progressive external ophthalmoplegia. Then you weigh your diagnosis in favor of an aponeurotic ptosis. This patient does not have a manifest high-lid crease because he has so much of extra skin there, right? So that is not giving you much clue. So you can definitely look at LPS action, and another test that you can do is ICE test and neostigmine test. So if suppose it is myasthenia gravis or chronic progressive external ophthalmoplegia, when you do surgery, what precaution would you take? If at all you have to do surgery, patient may be medically unresponsive, or if it is CPO, what precaution would you take?
We'll have to make sure that there is no lag of thalamus, and also the exposure of the cornea is not there.
Right. So you have to give him what he wants. It's not for cosmesis, but for function. The patient wants to see. So you'll have to expose the pupil. At the same time, you should avoid complications such as corneal exposure. So options would be safety enhanced surgery, where you would not just use a frost suture, but also a lateral suture tarsorrhaphy, which you release in a graded fashion so that the patient's cornea gets adapted. The second way to do it is to elevate the position of the lower eyelid. Lower eyelid can easily be elevated to the distance or the midpoint between the lower edge of the pupil and the lower limbus. With that, the patient will not have any difficulty in reading or looking at his mobile or something close by. And at the same time, lift the upper eyelid to the level of the upper edge of the pupil. So if you do this, you're actually shifting the palpebral fissure vertically without widening his vertical palpebral fissure. So the complications of exposure keratopathy, etc., will be much less if you do this procedure in a patient who may not be otherwise tolerant. Safety enhanced is a good option. Shifting the palpebral fissure itself is also an option. For resident level, I think that suffices. How do you do it and all is a totally different question. Okay, Ashwita.
In the primary case, the female looks like she's having ptosis in the left eye.
Yeah.
Which disappears on the closure of the other eye. So it looks like a case of pseudotosis.
Yeah, it is not completely disappearing. It is becoming better.
Plus,
So we are just making her fix with the right eye first. That is a natural fixation pattern. She's fixing with the right eye. She has manifest ptosis of the left eye, and she also seems to have hypotropia, right?
yes.
Yeah, and then when she is fixing with the right eye or attempting to fix with the right eye, a ptosis partially disappears. So as you rightly said, it is pseudotosis. Name 2 common clinical associations of this condition.
In ophthalmos,
In ophthalmos, why?
hypotropia, like in this patient.
Yeah, so in this
Uh,
kind of patient where there is, you also saw, I think, okay, fine. So if this patient has, hypotropia and her Bell's is poor, so what are the associations in terms of clinical associations? Monocular elevation deficit,
Monocular elevation.
okay,
Yes, sir.
and
DP,
synkinetic ptosis. Yeah, Marcus
yes,
Gun or any other form of
Marcus Gun.
synkinetic ptosis is an association. Amblyopia is the third association. Any patient with MED can have amblyopia, higher chance of having amblyopia. They also have a higher chance of having an associated synkinetic ptosis. Okay. How do you measure ptosis in this condition? How exactly can you measure ptosis in this condition?
I don't know.
Yes, we'll progressively go higher. Farnas.
We occlude the normal eye and check it.
Absolutely
The
right. So
ptosis.
occlude the normal eye. You make her fix with the affected eye and make your measurements. So you do it with right eye fixing and left eye fixing. When you do like this with the left eye or the affected eye fixing, the amount of ptosis that you see is the true amount of ptosis, right? That is the amount of ptosis that will be residual after she undergoes any muscle transposition procedure to correct her hypotropia, right? So finally, you'll have to correct this amount of ptosis and not this amount of ptosis. So your measurement should be with the affected eye attempting to fix. That is how you measure ptosis. Now, what is MRD3? What is its concept?
The measurement is to be taken in the up gaze from the highest point in the medial point in the upper lid margin to the corneal reflex distance.
Explain now.
From now, the patient is looking in the up gaze from the lid level to the corneal pupillary reflex.
Pupillary reflex.
Okay, the
reflex can fall anywhere. No, she's not fixing.
corneal
she's looking up. It is corneal reflex, right? It could be even at the limbus. It could be sometimes even at
lower limbus.
Yeah, lower limbus or anywhere between the center of the pupil and the lower limbus. So it need not always be. For example, in the left eye, in the right eye, look at the reflex.
Yes, sir.
Right? That is our MRD3, isn't it? So it's never
Yes,
at
sir.
the pupillary margin when the eye is normal. But when the eye is moving less, like the left eye is moving less, now this could be very close to the pupillary reflex. That is MRD3. So what is its significance? What does it measure? It's a favorite question of the examiners. This is a brownie point question. MRD3, otherwise we don't use it. It's an exam question.
For MED, the patients to rule out the case of
Nothing
MED.
to rule out. No, no, no. We're not ruling out anything here. Ruju.
Sir, in cases of double elevator palsy or mono elevation deficit cases, we do the MRD3 in spite of MRD1.
No, no, no. Why? Why do
For
you
the
do?
correction of
It is to decide the amount of surgical excision, surgical resection of levator. So levator resection depends on the MRD3. That is what Potaman proposed. Only in patients where you cannot or will not, or the patient does not want correction of hypotropia and the ocular motility in upcase, then you will use it as a measure. So how will you use it? You have, for example, 7 is the normal MRD3, which is absolutely right. Actually, the range is between 7 to 9 is a normal MRD3, okay, in a normal patient, minus MRD3 of the affected eye, multiply that by 3, gives you the amount of levator resection that you're supposed to do in a patient with monocular elevation deficit, where you will not do or cannot do extraocular muscle surgery to alleviate the hypotropia. So it is a very simple single statement with very clear words. There's no confusion at all. Okay, so that is MRD3 described by Potaman, and that examiners are fond of asking. We'll skip that. Now, management of this patient, well, basically we already discussed that you have to correct the patient's hypotropia first. That is the first thing that you would do. And then you address the true ptosis. So whatever extent hypotropia can be corrected. Some patients, you cannot correct the hypotropia completely. Patient may not have diplopia. So you just go ahead and address whatever is the residual ptosis. But before correcting hypotropia, you should never attempt to address ptosis, because you will end up with overcorrection if the hypotropia is addressed later. So give the option of hypotropia correction to the patient and the squint specialist. Give it a good consideration. And when that is done, as the last step of rehabilitation of the patient cosmetically, you address ptosis. Now you may ask, what if it's a 3-year-old child where you cannot do a definitive procedure? Then of course you can actually do dorsofrontal sling as a temporary measure, only as a temporary measure, with a promise that you'll reverse it and recorrect later. And in that situation, how to prevent amblyopia? You have to ask them to do very strict amblyopia occlusion regime. Okay, so that when the patient's right eye is occluded, she or he will be forced to fix with the left eye. So we'll move quickly. Okay, now it's back to Subhav.
Yes, sir. The photograph on the right shows that there is ptosis in the more prominent in the right eye. And a photograph on my right shows that on attempted movement of the jaw, improvement in the ptosis, suggestive of kinetic ptosis, complicated ptosis.
She looks a little sleepy on the right-sided picture. I don't think she has bilateral ptosis. She has right-eye ptosis. And on movement of the jaw to the left side, her ptosis gets corrected. Right?
Yes.
So what is it? Very simple question for you.
It's a synkinetic ptosis.
Yeah.
As marked on jaw winking phenomena.
Okay. So you absolutely rightly nailed it. It is Marcus-Gunn jaw winking phenomena. You committed because it is lateral pterygoid involvement, isn't it? Or external pterygoid, because when the patient is moving the jaw to the opposite side, ptosis is getting alleviated. So it is the lateral pterygoid in action. Suppose it were to get alleviated when the patient moved the jaw to the same side, right side, then it would be medial pterygoid. Then you will not call it classically Marcus-Gunn, you would call it simply as synkinetic ptosis. Suppose the patient's ptosis alleviated when she blew the cheek or protracted the jaw, right? Or even chewed on something, like used her temporalis. So any of the muscles of mastication can be involved with synkinesis. Buccinator, for example, masseter, any of the muscles. Then you simply call it synkinesis. So you commit to Marcus-Gunn typically when there is lateral pterygoid synkinesis. Okay, so more about that I think already has been covered in this thing. So how is it graded? This some of the examiners are fond of. Grading of synkinetic ptosis is very interesting for them. So how do you grade it?
There are two methods to grade it, sir. One is the amount of excursion of the lid which we observe on the attempted jaw movement.
Maximum jaw movement, maximum. So first you have to ask the patient to move the jaw in different directions, use all the muscles of mastication, and first determine which muscle is involved and what is the maximum extent of movement. Okay, then ask the patient to do that particular movement, then you grade Marcus-Gunn. Suppose a patient has medial pterygoid synkinesis, you cannot ask her to do something else and measure synkinesis. So first step is that, and then you measure. Yeah, go ahead.
And depending on what is the amount of excursion, that 2 millimeters, 2 to 4, more than 4 is one type
Sure.
of 2 to 5 and more than 5.
Okay, fine. So lid, most of the things you'll be right if you say less than 2 to 5. Okay, fine. So what is our second type, clinical type?
Clinical type is we compare the position of this improved position of the torticollis with that of the other eye lid,
No, it's nothing to do with that, right?
and the relation to the corneal reflex.
Mhm.
The limbus, superior limbus, we
Yeah, so partly right. So what you ask the patient to use the synkinesis to the maximum extent. If the ptotic lid returns to non-ptotic position, that is 2 millimeter from the upper limbus, that is mild synkinesis. If the ptotic lid elevates to the level of superior limbus, that is moderate synkinesis. If it elevates higher than that, and if there is scleral show, that is severe synkinesis. I'm speaking slowly, clearly, only because I want residents to understand this. This is very important. These questions are often asked and often missed. Right? So grading of Marcus gun is extremely important. Yeah, I don't have any pictures for it. The standard surgery, of course, depends on the amount of ptosis and Marcus gun. Then you enter into a discussion with the patient and the family. And if Marcus gun is mild and ptosis is severe, correct ptosis. If Marcus gun is severe and ptosis is mild, definitely you would want to correct the synkinesis, for which you'll have to remove the levator. Right? So you have to not resect but excise levator and support the lid with a tarsofrontal sling. Unilateral or bilateral is controversial. Suppose a patient has moderate amount of synkinesis and moderate amount of ptosis, that involves a lot of discussion. First two, clear and straightforward. Mild synkinesis, severe ptosis, correct ptosis. Severe synkinesis, mild moderate ptosis, correct both. If both are moderate, then enter into a discussion. Okay. Sixth question, I think, who's that for? Rujuji, yes. Simple question. I know why you got this simple question. What is the clinical diagnosis?
Sir, this is a young male with bilateral
How are
severe
you diagnosing the gender
right
by
eye
looking
more
at half the face? Okay.
right eye more than left eye
Are you
ptosis.
AI trained? Just look at the eyebrow or eyelashes and diagnose gender. Artificial intelligence is doing that apparently. By looking at the retinal pictures, it can, guess the gender of the patient and the orientation as well. Go ahead.
And inferiorly, there is a picture of red ragged fiber on meson trichome.
Very good. So, how does this red ragged fibers appear on routine HND stain? It appears black. Only on meson trichrome does it appear
As
red.
red ragged
What is
fiber.
it? What is it?
Basically, it's abnormal mitochondria.
Which is subsarcolemmal. It's a collection of abnormal mitochondria, subsarcolemmal, which appears as a rim of red around the muscle fibers, but it is subsarcolemmal. Okay, so that is histopathology. So you have to do a muscle biopsy to confirm the diagnosis. Based on the diagnosis, what else would you examine in this patient? And what is that syndrome?
So fundus evaluation for coincided and also for heart block.
Fundus examination for heart block.
Fundus examination for pigmented retinopathy changes and also
pigmentary retinopathy. Then?
And the most common systemic association is heart block, which is seen in almost 80 to 90% of the cases.
Perfect.
So systemic evaluation by cardiologist is mandatory in these cases.
Yeah, without that, you should never take this up for surgery because you may have sudden cardiac death, right? So it's very, very important that you subject these patients to a good cardiological evaluation. Even in the absence of pigmentary retinopathy, the patient may have Kearns-Sayre syndrome. It is called ophthalmoplegia plus or extended ophthalmoplegia or Kearns-Sayre syndrome, which has anesthesia complication. In fact, apart from heart block, sudden cardiac death is also known. And also in these patients, if you do neostigmine test, they could still have complications. So with or without anesthesia, just the neostigmine test can also have complications. So never do neostigmine test in a patient where you are suspecting chronic progressive external ophthalmoplegia until you have ruled out CPEO. So if it's a borderline case, go for fundus evaluation and ECG. And if a patient does not have any of those, then you can do neostigmine test. But without that, don't attempt to do it because these are known complications, reported complication, and nobody will spare you for having done that, having known that these are possible. Okay. So this is from literature. You know, the most common ones are abnormal retinal pigmentation and third degree arterioventricular block, a complete heart block. And less frequently are ataxia, EMG abnormality, hearing impairment, muscular hypotonia, etc. So there are a lot of systemic associations, and whatever that is possible, you should try to elicit in the clinic because all these forms a part of ophthalmoplegia plus syndrome. Okay, so the next question is for Naz, right? Yeah?
Yes, sir.
Okay. Simple questions, yeah. Tell me, what test did we do just now?
So the first test, we did
It's an edited video, so it was possibly a fatigue test that somebody was eliciting.
okay.
How old do you do fatigue test?
So from the primary gaze, we have to ask the patient to look up and down almost like 20 times. We'll
10
have
times.
so,
Yeah. And
so,
our second way of doing it is?
second way of doing it is we'll have to ask them to look up. So prolonged up gaze.
For how much time?
20 seconds, sir.
20 seconds.
Yes, sir.
Prolonged up gaze, I thought was for 30 seconds and up and down for 10 times. And if the drooping is more than 2 millimeter from its baseline, then you consider that as positive for fatigue test. Okay, so this was ice pack test, and the diagnosis obviously is ocular myasthenia. How do you confirm the diagnosis and name 3 ophthalmic signs of this condition? Now you have guessed that it is an ophthalmic myasthenia. You've done ice pack test. How sensitive and specific is it?
It's almost like 85 to 90% sensitive, sir. Sensitive and specific.
Yeah, somewhere close. You can also do sleep test and all that. Sleep test, obviously, you cannot do in the clinic, but about 80% sensitivity, which means that you will still miss about 20% of patients with this test. So if it is positive, patient has a very high possibility of having myasthenia gravis, 98%. It's very, very good. But at the same time, if it is negative, and if you're suspecting based on your fatigue test and other clinical evaluation, then you should go to the next level. Hydrophonium is possible, but not currently not. Neostigmine test is the next option. 1 to 1.5 milligram is given with atropinization under anesthesia support. You have to have an anesthetist close by because it does have complications and it is a delayed test. Whereas hydrophonium is a very quick test, neostigmine is a delayed test. It does not have immediate onset of action. So you will have to keep measuring the amount of doses even up to 30 to 45 minutes to declare it negative. If it is positive, sometimes even in 5 to 7, 10 minutes, if it becomes positive, you declare it positive and terminate the test. Just have to monitor the patient systemically. But if it is negative, to declare it negative, it's up to 45 minutes that you have to watch the patient, and only there are some 30% of patients are delayed responders. 70% are mid-level responders. They respond in 10 minutes, 15 minutes. But beyond that, there are 30% of patients who can go home and still have this positive test. right? So you should not let them go home for 45 minutes. Watch them completely until 45 minutes and then declare it as negative. Now, rest of the tests don't have much value. Acetylcholine receptor antibodies only 30 to 80% positivity. Decremental response is very good. More than 20% decremental response on EMG is a very, very sensitive and a specific test. And that is only supportive. Okay. So test for myasthenia clinical, supporting features, fatigue, we already mentioned. The second is Cogan slit twitch, enhancement and orbicularis peak sign. Can you quickly describe what is Cogan slit twitch and what is orbicularis peak sign?
Yes, sir. So we'll ask the patient to look down, and from down gaze to the primary position. When they look immediately, there will be twitching of the upper lid. So
Just
that will
keep
be
twitching. Does it keep twitching continuously?
No, sir.
Then what happens? What do you expect? Ask the patient to look down and ask the patient to look high up as possible. Lid twitches momentarily 2 or 3 times and settles down to its new position. New position is the fatigue position, lower position. So that is Cogan's lid twitch. Enhancement is?
Enhancement.
Nothing but what else do you check? Herring's law, how do you check? When you lift one lid, both of which will be ptotic, other lid will disproportionately droop down. Okay, so there is exaggerated Herring's. Orbicularis peak sign?
We ask the patient to close their eyelids, and after some time there will be like spontaneous widening
Opening.
of the
Yeah, it's like asking the kids to keep their eyes closed and they'll suddenly very curiously open their eye very little and then close. It's like that. The patient involuntarily has a peak where the pupil shows or the cornea shows and then the eye closes again. That's because of ill-sustained action of the orbicularis. The orbicularis gets tired and the eye opens. So that was it. Okay, now difficult question. I don't know how Ashwita is getting difficult questions. Diagnose, Ashwita.
The shape of the eyes in the first eye.
What about the shape?
It's anisochoric. There's mild ptosis in the right eye. And pupil is, so it's Horner syndrome. Perfect.
Very good. Okay, diagnosis you already said. Name 3 topical drugs that can be used to diagnose this condition.
Phenylephrine eye drops, hydroxyamphetamine, and apraclonidine.
Okay, pilocarpine?
Or cocaine test as well.
Cocaine, unless you are a peddler, you can get it. Okay, name 4 common features. Name common features.
Mild ptosis, anhidrosis.
Ptosis. Quickly.
Anhidrosis and meiosis.
Meiosis and there is no 4th one. And how do you differentiate if it is, how do you further work up? Somebody may ask this question. So basically you look for dilatation lag, which is a very common feature. And then if that is not there, sorry, I'll just go back to my pen. Yeah. You put 1% apraclonidine, none of the pupil dilate, simple anisocoria. If dilatation lag is present, which is a feature of this condition, then only the affected pupil dilates with apraclonidine, then that is Horner syndrome. Then you can do for the phenylephrine test, right? So this is how it goes. This is the diagnostic tree. We don't have time to explain in detail, but it has been completely covered in the evaluation of acquired ptosis. And these are the 3 etiologies, common etiologies: multiple sclerosis, Pancoast tumor or bronchogenic carcinoma of the superior fissure or the apex of the lung. And one more association is cluster headache. Patient who has cluster headache, it's also called Horton's syndrome. And as far as the 4 features are concerned, you have to use this mnemonic, which is Pamela, right? Ptosis, anhidrosis, meiosis, enophthalmos, loss of ciliary spinal reflex, and anisocoria. right? Meiosis obviously means anosogorrhea, but this is a very popular mnemonic. Tamil. Okay. 9th question. Go back to Subhav. You've seen this lady many times. All my lectures have it. Go ahead.
There is a retraction of the right upper lid.
You think it is retraction or it is left eye ptosis?
It is retraction of the right upper lid.
You're sure? I would say it is left eye ptosis with compensatory upper lid retraction of the right eye. Yeah, because left eye lid crease. Look at the lid crease. This is a lady, right? Young lady. So you should not have a high lid crease like this, right? So the fact that she has a high lid crease indicates that left eye is abnormal. Right eye may be retracted because of whatever. So we say she has 2 millimeter ptosis and 10 millimeter levator action. What baseline drug test would you do to decide surgical options and how? What are the surgical options? I don't know how we are getting such simple questions.
Okay.
Quickly. In a patient with mild ptosis with good levator action, what is the drug test that you do to decide surgical options and how?
We do a phenylephrine test.
Okay. What is the percentage and where do you put the drug and what do you see?
Okay. So 10%.
10 is too high.
Yeah.
Because you don't want dilatation, isn't it? So minimal dilatation, maximum effect, 2.5%. If you don't have 2.5 available, you can always compound it. Correct. So 2.5% is the ideal concentration. You put it in the superior cul-de-sac as most drugs are put in the inferior cul-de-sac. But here is one situation where you put the drop in the superior cul-de-sac, ask the patient to look down, put a drop, okay, before which you measure the amount of ptosis, ask the patient to keep the lid closed, and after 2 minutes, you remeasure the ptosis. After 5 minutes, you remeasure the ptosis. There are some late responders, so you cannot declare it as negative until 30 minutes. Okay. So if there is more than 2 millimeter or at least 2 millimeter, 2 or more millimeter increase in MRD1 or vertical palpebral fissure, then you call this as positive. So alternative to phenylephrine, can you use any other drug?
Apnic.
Apni, well, it's for treatment. Testing. Apraclonidine. You can use apraclonidine, right? So there are studies which are comparing phenylephrine versus apraclonidine, and even in phenylephrine negative patients, people are doing mullerectomy. So that is the surgical approach. If phenylephrine test is positive or apraclonidine test is positive, you have an option of performing mullerectomy. Correct? But if it is negative, then you can still do mullerectomy. It does work in about 70% of patients, even if it is negative. But it should be indicated, which means that there should be no lash ptosis. The patient should not have a tendency to entropion. There should not be dry eye. All that being met, you can do mullerectomy. So surgical options clearly are mullerectomy. And the second surgical option is, of course, anterior approach, where you plicate the levator aponeurosis or do a minimal resection, or, of course, Fassler-Savart procedure. Alternate drug, I already asked and you answered. What is the name of the classic instrument used for mullerectomy?
That is Putterman's clamp.
Putterman's clamp. What exactly is excised in Fassler-Savart procedure and what is the calculation?
For every 2 millimeters of ptosis, 4 millimeters of the tarsus is...
Yeah, you can simply say for every millimeter of ptosis, 2 millimeter of tissue is excised. So, and what tissue is excised?
Conjunctiva, the tarsus,
and molars. So it is called tarsoconjunctival mullerectomy. How much of conjunctiva is excised? Trick question. Tarsus is 4 for 2 millimeter ptosis. How much of conjunctiva is excised?
Yeah.
Huh?
Double
because the lid is folded, isn't it? 4 millimeter of tarsal conjunctiva plus 4 millimeter of palpebral conjunctiva is excised. So 8 millimeter of conjunctiva is excised. It's almost like mullerectomy. except that you are excising additional tarsus, right? Because for 2 millimeter ptosis, for mullerectomy, you excise 8.5 millimeter of mullers by Butterman's rule if phenylephrine test is positive. Here you're excising 8 millimeter, and the only change is that you're excising tarsus as well, so the effect is going to be better. Tuju. Bilateral severe ptosis with poor levator action. What is the ideal surgery for this 8-year-old child?
Tarsofrontalis sling.
Absolutely right. Name 4 qualities of an ideal sling material.
Non-biodegradable, biointegrable.
You want biointegrability, is it?
It is
Okay, fine. That's your choice. Go ahead.
biologically inert, flexible, reversible, adjustable.
Reversible and biointegrable don't go together. Fasciolata is biointegrable, not reversible. Silicone is non-biointegrable, so reversible and correctable, isn't it? So if somebody asks you this question, you'll have to say all this. Biocompatible, non-biodegradable, reversible or biointegrable. These are mutually exclusive qualities. Adjustable, flexible, should be easily available and should be easily handleable. So easy handling. And if you're all looking for a spouse, these are the qualities that you would look for, isn't it? Right? Except reversibility and not, that is your choice, personal choice. But just simply remember the quality of spouse that you want. And Subha, I'm sure, has looked for all these factors. Okay, so that is how the quality of sling material also, the kind of grossly. Now, the next question is name 4 materials that are commonly used for this surgery.
Silicone, fasciolata, ethibond, and proline.
Okay, ethibond is brand name. So you want to talk about the correct name.
Purely butyrate coated.
Polybutyl. Okay. Polybutyrate coated.
Terephthalate.
You can simply say polybutylate coated braided polyester. Okay. So if you want to further categorize polyester, that's fine. If you want to remember so much. All right. So that's done. 11th question. 11th question is for Farnas. Yes. You keep getting similar pictures. Huh?
So this picture of an elderly gentleman shows
Brotosis and
also there is like a skin fold in both
what is
the
it
eyes.
called? Dermatocalasis or blepharochalasis?
Dermatocalasis.
Okay. What is the difference between dermatocalasis and blepharochalasis? Are they interchangeably used? Ruju?
Sir, blepharochalasis terminology is particularly used for young individuals in which there is recurrent episode of blepharitis.
You can't call it blepharitis. Well, inflammation, preseptal inflammation, and that causes progressive stretching and laxity of skin and thinning of the skin. Whereas this elderly individual, you have to use the term dermatocalasis. Okay, so these terms are not exchangeable. Now the questions would be diagnosis, already said, define tarsal platform show, define bro fat span, name 2 long-term complications of blepharoplasty.
Tarsal platform show, it is the distance between the center of the, like in primary case, the distance between the center of the upper lid margin to the lid crease.
To the lid crease. So if this is it, correct? When the patient is looking straight.
Primary case, yes.
Yeah. So how is it different from margin crease distance?
So margin crease distance is measured in down gaze, sir.
Down gaze. Do you have a lid crease when you look down?
So we ask the patient to like look down and from there.
Yeah. So you ask the patient to look down, extreme down, and ask the patient to very gradually look up. The first prominent definitive lid fold that appears when the patient looks from extreme down gaze up gradually is the lid crease. From there, you measure the distance to the lid margin in the center of the pupil, and that is your reference points are always the center of the pupil and center of the superior orbital margin, right? That is your two reference points that you have. So that is the margin crease distance. Whereas when the patient looks straight up, like primary position, and then you measure that distance, it's called tarsal platform show. The difference between the two is that there is some amount of skin that overhangs the lid crease, isn't it? So that is taken into consideration to measure the tarsal platform show. That overhang as it looks natural when the patient looks in primary position. So this is what the patient would want after blepharoplasty, a adequate amount of tarsal platform show, which is age, gender, race dependent. So based on which race they are and age and gender, you don't have to feminize males and vice versa. So you will have to give them a good, reasonable tarsal platform show. Name two complications of blepharoplasty. Upper lid. Most important complication which most of these patients suffer unknowingly, and you don't even measure.
Lid lag, sir.
Hmm?
Lid lag.
Dry eye. Dry eye is the most important complication of blepharoplasty. And next is denervation of the upper eyelid, loss of sensitivity, sensation of the upper eyelid. These are the two complications of blepharoplasty, common complications. Next question. Yeah, Ashwita, quickly.
She has epicanthal folds, inverses,
Epicanthus inversus. I won't ask you what are the types of epicanthal folds.
BP.
No, that's
It's a case.
Study. Go ahead. Next.
The case of BPES.
Complete answer. What is BPES?
Blepharophimosis, epicanthus ptosis, and epicanthus inversus.
Syndrome. Okay, fine. So what is the clinical type of this patient? These are the questions that you have to answer. What is the clinical type of this patient? You don't know about ovary, so don't talk about ovarian dysgenesis type.
This is type 1.
How do you know? Which type are you talking about? There are two types. One is based on ovarian dysgenesis. The second is based on clinical features. We don't know about the gender of the patient. I have not told you about it. We haven't tested the child genetics, or we haven't looked at the ovaries. So we don't talk about that type or classification. We are only talking about clinical classification, which is asked in the exams, which nobody answers, unfortunately. So you have to know about it. And how do you define blepharophimosis? How do you define telecanthus? And name 4 components of the corrective surgery. Very quickly, 30 seconds.
Blepharophimosis is shortening of the horizontal lid, the
horizontal palpebral fissure. Is there any cutoff?
Less than 8 mm.
Parnas? Ruju?
6, less than 6.
No. Ruju? Keep your mic on. How do you define blepharophimosis? Come on.
Is a horizontal shortening of the palpebral fissure less than 20.
Well, of course, 18 to 20 is what is written, but it is always age, gender, and sex dependent, no? Age, gender, and race dependent. Okay, so whatever is appropriate for that particular age, gender, 2 standard deviations less than that. That is what is the definition, but grossly books mention, or even articles mention, or research is done on with the definition of 18 and 20 millimeter, 18 in children and 20 in adults, that is acceptable. Telecanthus?
It's increased distance between the medial canthi.
Which is more than twice the interpupillary distance. So you have
Interpupillary
to measure
distance.
IPD, and only when you have measured IPD can you define telecanthus. Otherwise, you cannot define telecanthus, because once you have measured IPD, if it is 60, if this is more than 30 intermedial canthal distance, then you call it telecanthus, right? Name 4 components of the surgery. And before that, I want to, this is important because you may not find it in recent books, right? This is the classification that is expected. Type 1 is blepharophimosis, which all of them have epicanthus inversus, telecanthus, and ptosis. This is classic blepharophimosis. This patient is type 1. Type 2 is this, obviously, one second. Yeah. It's written there, no? You just read out if you want. Medial entropion. Whenever a patient has medial entropion, type 2A is medial entropion. Type 2B is medial blepharophimosis, lateral entropion. Though this patient has a tendency for it. You see, the distance between the medial limbus and the mitral canthus is hardly a millimeter. The patient does not have isotropia. This is pseudo. And the distance between the lateral limbus and lateral canthus is almost normal, and the patient has a slight tendency for lateral ectropion. So this patient, you can argue that the patient could be type 2B also. This is called lateral ectropion. This is called medial blepharophimosis because there is so much of telecanthus that the medial limbus to medial canthal distance is totally obliterated. So that is type 2B. Type 3 is hypertellurism, which is a radiological definition. So you have to actually then do a CT scan or X-ray and then ask the radiologist to measure inter-pterion distance to determine whether a patient has hypertellurism or not. Okay, more about that in proptosis classes. But basically, you have to determine if the patient has any of these to classify clinically. Okay, most of the patients are type 1 blepharophimosis. Type 2B is next most common, and type 2A is third more common, and type 3 is the rarest of all blepharophimosis. Based on that, the surgery also has to be designed appropriately. The implication of this clinical classification is the type of surgery that you do. Okay, going back to Subhav. Yeah, the question is very simple. Name the rules that govern pentagon excision. Subhav?
Yes, sir. The two sides are parallel to each other, and the
Two
oblique
sides means the two edges of the pentagon.
vertical limbs of the pentagon
are parallel to each other. Okay, then.
And the oblique ones go beyond the margin of the tarsus and are in the ratio of 2:3.
Okay, so two edges are parallel, and if possible, they have to be of equal height. Sometimes you have to do lopsided. If you're doing a medial pentagon, obviously it will be lopsided. The medial limb will be shorter than the lateral limb, but you have to keep it parallel. We are talking about the upper lid here. So this is the height of the tarsus. So each limb has to correspond to the height of the tarsus and not go beyond the vertical part of the pentagon. Suppose this is 6 millimeter. Suppose this is 6. Then the triangular component has to be 4 millimeter. So that gives you the ratio of 3:2. Suppose this is more. Suppose this is 9. Then obviously this has to be 6 millimeter. Okay. So 3:2 is the ratio. This has to be square edges, absolutely parallel, equal in height if possible, and ratio of 2:3. That is the rules for the pentagon. What if the edges don't come together?
We can
Like
do
this patient. We have excised a pentagon. There was a tumor that has been excised. And unfortunately, in tumor, you don't bother about reconstruction first. You bother about excision of the malignant tumor first. We excise the tumor and the pentagon has become a little broad. So how do you do?
We do a lateral cantholysis to basically
So first you do a lateral canthotomy and an inferior cantholysis. So if the edges don't come together, that is the next step. And if you think that even that will not help, then you quickly convert it into a tensile, right? So I haven't asked you about the suturing rules of a pentagon. That is for people to read up. Name 4 common procedures for full thickness eyelid reconstruction. Just name randomly, quickly.
Cutler beard, cutler beard, reverse cutler beard, tensils, and what? Hughes procedure. Yeah.
Okay. Ruju, you like strawberries?
Sir, it's a case of infantile hemangioma.
Infantile capillary hemangioma or infantile hemangioma. Okay.
Of the upper lid.
What is the suggested theory of origin? Current suggested theory of origin. It's no longer current, it's become old. Theory of origin. There are 2 types, you're aware of it. Congenital and infantile. Correct? Congenital arises from progenital cells or stem cells. Infantile can have a different origin. And what is that origin? Placental theory. Placental embolization. It shares the antigenic nature with maternal placenta on histopathology and immunohistochemistry. So there is a theory that there is bit of placenta that get embolized and that settle down in the child in various subcutaneous areas. It could be at the tip of the neck, it could be even in the soft palate, they could have anywhere, but mainly it is more common in the face, right? So that's the placental theory, placental embolization theory. Name 2 syndromic associations.
Maha syndrome, faces.
Maha. Okay. Maha, what is Maha?
Microangiopathic.
Microangiopathic. Complete it. You have said it. You have to complete it. Hemolytic anemia. Casabrac-Merit is more common. So you should, I think, start with Casabrac-Merit because it's more common. It is consumption coagulopathy. That's it. So if you say those 2 words, everybody would be happy. You don't have to explain much. Maha is microangiopathic hemolytic anemia. Faces, sacral, pelvis, ONSP, Maffucci. There's a lot to answer and impress examiners in this because it's a very, very nice question. There's a lot of information that you could give. And this slide has it all. We don't have time to go through each one of this, but you should at least remember Casabrac-Merit, which is very, very popular, Maha and faces. Sacral, pelvis, you can remember because these are, it's so logical to remember all this, isn't it? But if they ask you what are the components, then you really have to scratch your brain and answer. If you answer all that, I think it's going to be really good. Now, what I would also like you to understand is the components. I've written it here, but also the fact that there are 2 variants, congenital, where there are 2 types, rich and niche, rapidly involuting capillary hemangioma, non-involuting capillary hemangioma. Rapidly involuting are the ones which disappear in 3 months or 6 months. Non-involuting are the ones which remain stable, stationary. They don't change much. So there is actually now a concept of treating each one of these after categorization. If the non-involuting capillary hemangioma, they don't have much of anti-VEGF activity happening in them. They don't have much of cells that will respond to oral propranolol. So they may actually come to oral intralesional steroids. Whereas if it is infantile stem cell placental origin, where there'll be high matrix metalloprotein 9, VEGF, positive GLUT1. In fact, positive GLUT1 on immunohistochemistry is the differentiating feature between the congenital and the infantile origin, apart from the pictures that you see, which the parents show you. Correct? So that is only on biopsy. You don't go ahead and do biopsy, but basically infantile are the ones which seem to be responding better to oral propranolol and topical timolol, whereas the congenital ones, the NICH ones, are the ones which respond favorably to intralesional steroids. That's for your fellow knowledge, not for residents. Okay. Farnaz.
So this picture shows left eye. There is like a lesion which is involving the like upper lid, medial part of the upper lid extending to the
forget about it. What is the most likely diagnosis? Description is good, but yeah.
The most likely diagnosis I would say is like basal cell carcinoma, sir.
Perfect, perfect. Names to standard management approaches.
So we'll have to do a wide local excision with clinically clear like margins of 4 millimeters.
Hmm.
And we have to do an intra frozen section as well.
Okay.
And
Surgical excision is one of the management approaches. Perfect, as you said. Second management approach, which is equally beneficial. There is a nice survey of ophthalmology, old article, which has compared radiation versus surgical excision in extensive BCCs and found that cure rate is almost comparable. Right?
yes.
But the disfigurement will be there because this larger lesion, when it is irradiated, will lead to a lot of disfigurement. Patient will not be cosmetically benefited. So surgery could still be considered, but radiation is a good option. Name one syndromic association. If a patient were to be young.
Syndrome, sir.
Perfect, perfect. What are the indications and the drug used for target therapy of this patient?
If it is a locally advanced basal cell carcinoma, we can go ahead with immunotherapy, that is targeted therapy. The drug used is vismodegib.
Perfect, good. So that's done. Next. We're running out of time, so next. Ashwita. Diagnosis. Most likely diagnosis.
A conjunctival papilloma or a sebaceous gland carcinoma.
Okay, sebaceous gland
Sebaceous.
carcinoma is more like it. It's not a papilloma, it's a yellowish tumor with specks of white within it. Lid margin is disturbed. You don't see meibomian gland orifices in that area. It's posterior, tarsal conjunctival. So sebaceous gland carcinoma is the correct answer. Syndromic association.
Moore-Torre syndrome.
Perfect. So what are the oncological principles of surgical management?
Complete excision with free margins of 4 millimeters.
4 millimeter clinically clear margins, intraoperative frozen section, and conjunctival map biopsy to rule out pegytoid invasion, and adjuvant treatment as appropriate. That is this oncological principle. And lymph node evaluation. Name 4 standard prognostic factors.
The duration is more than 6 months.
Yeah. So duration of the tumor more than 6 months, large tumor more than 10 millimeter in diameter, vascular, lymphatic, and orbital invasion. These are all from Rao and Hidayat, Narsingh Rao and Hidayat, who are the ones who elucidated these risk factors in a series of about 100 plus long ago. But despite multiple other studies, these still hold good, right? So involvement of both the upper and the lower lid, that is multicentric origin, poor differentiation, and you already said duration of symptoms more than 6 months, or the longer the duration versus the prognosis, and tumor which is more than 10 millimeter in diameter, and pegytoid invasion. Now, pegytoid is not just pegytoid, it has 3 types. It's called intraepithelial invasion currently. It has 3 types: pegytoid, bovenoid, and papillary. Each one of them has a different prognosis. That is some relatively newer understanding. So you should know about all this, and a high infiltrative growth pattern. And we already mentioned about intraepithelial invasion. These are the prognostic factors. Out of these, you can mention any 4, but in the order of preference, I would say the first one would be the diameter of the tumor. Size has an important bearing on TNM classification and also the prognosis. So 10 millimeter is something that you would want to say first, followed by intraepithelial sebaceous gland carcinoma, that is pegytoid invasion, you can say as the second. Third would be multicentric origin or involvement of both the upper and the lower lid. And the fourth risk factor, which is very important, is vascular, lymphatic, and orbital invasion. All these in that order have a bearing on local tumor recurrence, regional lymph node metastasis, and systemic metastasis. Okay, so that's done. So I'll skip the video, going to the next question. Subha. What test is this?
This is a fluorescent dye disappearance test, which is positive.
Okay. Next question. If in lacrimal syringing, if there is immediate regurgitation of clear fluid from the opposite punctum, what is the diagnosis?
That means we have irrigated the lacrimal sac and the obstruction is at the level of the sac NLD junction.
How do you know? Immediate regurgitation of clear fluid from the opposite junction. It could be NLD block with a small fibrous sac, or it could be even common canalicular block, right? So don't commit to NLD block. If there is no regurgitation, but the patient gets no fluid, then
Atonic sac.
okay, or
Like
or you're syringing, you're not getting any regurgitation, but the patient doesn't get any fluid either. You have to go through this.
yes.
So fluid injected, but no sensation is felt in the throat. And on probing, you find hard stop. That means canalicular system is fine. Okay. Then it could be atonic sac. Sac is, but sac is retaining the fluid. In atonic sac, typically
When
there is
application,
patent NLD on pressured syringing. So that is a lower concentration. So when there is a hard stop and fluid is not felt in the throat, then what is your major concentration? You would think of an internal fistula or a diverticula. Correct? And if it is painful, when you inject, if it becomes painful, then it is false passage. So remember this because this is very important. This particular diagnostic tree for probing, if you take a picture and fill in for each of this, I would expect each of you to take a picture and fill in for each of this, then your lacrimal diagnosis will immediately improve. There are only about 10 scenarios here. Okay, just take a screenshot of this and fill in and show me. Next question. This is for Ruju. A 24-year-old man has a recurrent lacrimal sac lesion, status post DCR elsewhere. What are the differential diagnoses? Ruju?
Sir, probable case of NLT mass.
Because it is higher than the medial canthal angle, it is involving the fundus of the sac. So in such a situation, in a young patient, you could think of a sac granuloma such as tuberculosis, sac tumor such as papilloma, even rhinosporidiosis in an endemic area, or a sac tumor, malignant or benign. So these are the considerations. Next question, name 4 causes for a blood-tinged regurgitation on lacrimal syringing. 4 causes.
Dacrylolith,
Good.
iatrogenic, granuloma, and malignancy.
Tumor. Perfect. What are the 2 specific investigations that you would do in this patient?
As the patient has already incision, probably we can send that specimen for microbiology.
I haven't done a
and
biopsy.
MRI.
The first thing you would do is a scan, CT or MRI scan, to see if there is really a tumor or if it is just, infection. Okay. The second test, of course, you would do an incisional biopsy and even do a nasal endoscopy to look at. But the most important clue here is unilateral telecanthus, isn't it? So whenever a patient has a sac mass and there is unilateral telecanthus, that means medial canthal tendon has been displaced laterally. That means that there is an infiltrative mass, which is or a mechanical push of the medial canthal tendon. So you are looking at something which is in the ethmoid or a solid lesion within the sac that is causing this abnormality. So always in an NLD situation in a young patient, look for unilateral telecanthus. And if a patient has unilateral telecanthus, look for secondary causes for NLD obstruction, not concentrate on primary NLD obstruction. Okay. Farnas. 24-year-old lady has undergone enucleation for trauma 3 years ago and is unable to wear a prosthesis. What is the complete diagnosis? Farnas?
Yes, sir.
Yeah. Acquired anophthalmic.
Yes, acquired an ophthalmic socket.
Yeah. Contracted socket with
Socket.
volume loss because she does not seem to have an implant and Surface loss. What grade? Wet. That also you have to mention. What grade?
Grade 2, sir.
Grade 2. Okay. How do you grade then? Do you know what is the grading mechanism that is used? One is mild, moderate, severe, but examiners expect an Indian grading. Unfortunately, the person who wrote it up does not even practice oculoplasty. He's a very prolific cataract surgeon.
The
It
Gopal
arose out of a thesis, PG thesis.
Gopal Krishna classification.
Absolutely right. So that's what the Indian examiners expect. Otherwise, if you are not from India, then you don't worry about this classification. This is Gopal Krishna classification. There are 6 grades here, 0 to 5, 0 and 5 included. 0 is when the patient is able to wear a prosthesis. Grade 1 is shelving or shallowing of the lower fornix. Grade 2 is both the upper and the lower fornices are shallow. To determine that, you have to first fix the lower fornix into its position using a cotton tape applicator or a blunt instrument. Then assess the upper fornix. Otherwise, you'll always assess one fornix as shallow and the other assess as normal. Grade 3 is loss of superior, lower, medial and lateral fornices. Grade 4 is loss of odd fornices with reduction of the palpebral aperture horizontally. And grade 5 is a malignant contracted socket. That's what is Gopal Krishna classification. Okay. Now let's skip this because we already covered it. Now mention the management in this patient where there is both volume loss and surface loss.
We can go ahead with a dermis fat graft. Sir.
Yeah, so if there is minimal surface loss, you can actually use a secondary implant. How do you assess that? You fix the lower fornix first using a blunt tipped instrument or a cotton tip applicator, then see what is happening to the upper fornix. If it really does not move, then it's just a lower fornicial prolapse that is happening. Then you can go ahead with the secondary implant and reformation of the lower fornix. That's a reasonable option. Suppose the patient has both surface loss and volume loss, then you should go for a dermis fat graft. Yeah. Ashwita? That's the video that Ruju gave me. 24-year-old male again. I don't know why everybody is 24-year-old today. Has undergone enucleation for retinoblastoma in childhood and is unable to wear a good prosthesis. That means a prosthesis of good cosmesis, which is matching the other eye. There is no implant. What is the complete diagnosis?
Acquired wet.
Acquired, same question actually. Acquired anophthalmic
socket.
Contracted socket with obviously volume loss and surface loss. Yeah, so there doesn't seem to be an implant. So answer is going to be the same. You probably would go for dermis fat graft. Yeah, Subha, identify these as a category. Orbital implants. Okay. What are the types? Quickly.
Autologous.
No. Non-integrated, semi-integrated, integrated, biointegrated, and biogenic. Okay, please go back to my socket talk for the details. Right? How is the size determined?
The norm is like axial length minus 2 millimeters can determine.
Reader's formula. Axial length of the normal eye minus 2 millimeter is the size of the implant if it is not coated. Coated in the sense it is not covered with sclera or any other material. Second is to determine intraoperatively by using implant sizes which are inserted into the orbit. Third is to look for mooning of the implant as you put in a standard-sized implant, and if it spontaneously comes out, like moves up, that's called mooning of the implant. That means it's possibly little larger than what you want. These are the 3 ways of determining the implant size. But the most reliable way, of course, is excellent minus 2 millimeter. What are the common complications of these implants?
Implant migration.
Migration, exposure, extrusion. Very good. Okay, so this is obviously thyroid related eye disease. Name 4 eyelid signs, Ruju.
Geoffroy, Rosenbeck, Jelly.
I'm showing you.
and Roth, Jelinek.
All right. So this is the series of eyelid signs. So you can actually classify these signs as eyelid signs, muzzle signs, globe sign, and pupillary signs. And remember this is a part of the thyroid lecture. But basically you have to remember the signs. These are important for you to remember. And the next question I thought was asking about the management that has been covered. But basically currently we depend on, for active diseases, intravenous methylprednisolone pulse therapy, low dose, and that is followed by immunomodulators depending on the initial response, which is a prolonged immunomodulation with azathioprine or mycophenolate mofetil, and then do a rehabilitative surgery. And whenever you do rehabilitative surgery, you have to choose a patient who's inactive for at least 6 months. Then you follow the sequence: decompression first, followed by squint surgery, and finally lid last, eyelid procedure. Never reverse the order. Okay. Farnaz, what is the most likely diagnosis?
The patient has an S-shaped ptosis, sir, so it is most probably
There are two patients here. One is medial, one is lateral, both by birth.
yes, sir.
Dermoid?
Dermoid, sir.
Yeah. Is dermoid a heterotopia, choristoma, or a teratoma?
Dermoid is choristoma.
Choristoma, correct. So when there is a normal tissue in an abnormal area which does not form a mass, it is called heterotopia. When there is a normal tissue in an abnormal area that forms a mass, it's called choristoma, right? And
Yes.
teratoma is when it is from germinal layers. You know, the mature teratoma would have all the three germinal layers. What are the types of orbital dermoids?
Angular.
This is how you classify extraosseous and osseous. In extraosseous, obviously, it could be in the soft tissue of the orbit, free within the orbit, basically, not in any sutural relationship. And this soft tissue extraosseous dermoid could be superficial in the orbit, which means that it is mainly subconjunctival, conjunctival, subtenons around the muscles, etc. Deep is a deep orbital dermoid, which is a different entity. It has very thin walls and difficult to excise. Then extraosseous could be juxtasutural around the sutures. It is not attached to the suture in a definite way. Only a slip of periorbita goes through the sutures, through the dermoid, enclosing the dermoid, which is easy to excise. Sutural are the ones where one of the walls of the dermoid are incorporated within the suture. These are slightly difficult to excise because they tend to rupture when you dissect it. Next is the osseous dermoids, which could be further classified as intraosseous, which is partially within the bone or completely within the bone. Then it could be intraorbital, confined to the orbit, but intraosseous. Extraorbital, where part of the dermoid is outside the orbit. Multicavitary, where it involves the temporal fossa and the brain. So this is the systematic classification of orbital dermoids. Treatment, of course, excision is the treatment of choice. And if a patient wants no scar from surgery, then currently we have the option of doing sclerotherapy. Okay. Ashwita, what is the most likely diagnosis in this 50-year-old male with gradual proptosis of the left eye?
Cavernous hemangioma.
All right, I will take that. Differential diagnosis of a well-circumscribed orbital mass.
Schwannoma.
Correct.
Orbital
Cavernous
meningioma.
hemangioma, we already said. Schwannoma or neurolemoma. Then you have neurofibroma, fibrous histiocytoma, primary malignant melanoma. There are a lot of things, but these are the top 4 ones, out of which most common is cavernous hemangioma and neurolemoma. Okay. Then we go back to Subha.
These are
Coming at you. Yeah, this disc.
showing optociliary shunt vessels
Correct.
with vertical folds.
So most common, most likely diagnosis.
Any intraconal mass like meningioma?
Yeah, so most likely diagnosis would be an optic nerve sheath meningioma. What sign do you expect to see on MRI or CT scan?
Tram track.
Tram track sign. Do you see the same in MRI and CT scan, or is it CT only? You see the same in MRI and CT scan, but in different. In CT scan, the calcium is white, whereas in MRI, calcium is black. Otherwise, it is tram track. So in a negative and a positive image of a tram track is what you see in MRI and CT scan. Otherwise, it is called, that is in axial cuts, right? But in coronal, what sign is it called? Very interesting. You should know all this. What sign is it called in coronal cuts? Donut sign, right? Because there is a central lucency. You can even call it a Vada sign. Okay. So which systemic disease may be associated?
Neurofibromatosis.
Absolutely. NF1. What is the treatment of choice? External beam radiation, stereotactic radiation. Okay. So this is for Raju. Child.
Sir, probably a case of orbital floor fracture with inferior
Okay.
rectus entrapment.
Perfect. Perfect. Theories associated with orbital fracture.
Basically, there are two theories, hydraulic theory and buckling theory.
Good, very good. What is pure fracture and what is an impure fracture?
When it does not involve the orbital margin,
Rim.
it is called pure.
Okay, when it involves, it's impure. What are the indications for early surgery?
Oculocardiac reflex, muscle entrapment, diplopia.
So you classify it as immediate surgery and early surgery. Immediate is when there is a white eye blowout fracture where there is a risk of muscle ischemia because the muscle is entrapped in a tight fracture, and if a patient has oculocardiac reflex, okay, because it's a tight fracture, especially happens in a child, white eye fracture, or diplopia with in primary position, and if a patient has a fracture which is larger than 50% of the floor, inophthalmos of more than 2 mm, hypoglobus of more than 2 mm, progressive infraorbital nerve hyposthesia, then you do an early surgery in about 2 weeks' time. So initially treat the patient with steroids, reduce edema, and go back to surgery. And if patient does not have any diplopia in functional positions of gaze, negative FDT, very minimal inophthalmos, less than 1 mm or 1 mm or less than 1 mm hypoglobus, then you can observe. You don't have to operate. So this is the current guidelines for orbital fracture repair. Yeah. This is for Farnaz. You see a thickened inferior rectus muscle. What is your diagnosis?
Thyroid eye disease.
Insertion.
Myositis.
Myositis is a likely diagnosis. How do you do a muscle biopsy? If you're called upon to do a muscle biopsy, this is the insertion. How exactly would you do it? Would you do it like this or would you do it like this? You're always supposed to do muscle biopsy along the axis of the muscle from the thickest portion of the muscle, the belly of the muscle, without going full thickness because don't want to meddle with the innervation of the muscle, right? Yes. So in a cross section, if this is the muscle, it would look like this. That's how you would do the biopsy from the belly of the muscle, thickest portion of the muscle along the axis of the muscle so that you don't tectonically weaken it. You can put a couple of sutures through it, the muscle becomes integrated again. Okay, what is the standard management of myositis? We already, just like thyroid eye disease, you start with intravenous methylprednisolone steroid with or without immunomodulation. Most important question. Name 4 causes for extraocular muscle thickening.
One is non-specific orbital inflammation, which is myositis. It can also happen in thyroid eye disease.
Okay.
And lymphoma.
Okay. Tumors, metastatic or primary. Then?
Then hydatid cyst.
Infection. Okay. Then?
And
hydatid cyst, not hydatid. Cysticercosis, myocystis. Okay. Yes. Then?
And
vascular. Which one?
Keratico-cavernous fistula.
Absolutely. You should always remember non-thyroid, extraocular muscle thickening. One more you forgot was xanthogranuloma. Moth-eaten appearance of extraocular muscles is a perfect example for xanthogranuloma. Okay. Ashwita, last question, I think. What do you see here?
Superior ophthalmic.
Perfect. So it's a dilated superior ophthalmic. Most likely diagnosis is
cavernous sinus thrombosis. No.
It is contrast enhancing. So it is keratico-cavernous fistula. If it were to be dilated and if it is not contrast enhancing, that's a straightforward diagnosis of cavernous sinus thrombosis. But if it is dilated and is enhancing with contrast, straightforward diagnosis of keratoconus fistula. Very, very clear. Thrombosis does not enhance, fistula enhances. That's an enhanced CT scan, contrast enhanced CT scan. Name important differential diagnosis we already talked about. What are 4 causes for pulsatile proptosis?
Cavernous and keratocavernous fistula, encephalosis,
We saw one today, right?
encephalosis, and the floor superior roof fracture of the orbit.
Roof fracture, yeah. Then neurofibromatosis with sphenoid dysplasia, bare orbit, right? Or even in arteriovenous malformations with very rich vascular supply. So all these are the conditions where you see pulsatile proptosis. So that's about it, 28 questions, and I think we overshot time by quite a bit. Sorry for the long haul, but anyway, these questions will be useful. These are just samples. There could be hundreds of questions in OSCE. My suggestion for all the exam going candidates is to make your own OSCE, or ask your friends to make 20 OSCE each, and everybody makes 20 OSCEs, and if you have 200 OSCEs, that's it. Beyond that, no question will ever come or can ever come. So keep on making OSCE and keep answering them, because that's the best way to learn ophthalmology specifically for the exams. Thank you so much.
Thank you very much, sir, for the wonderful session. I'm very sure it will be of great benefit to all the postgraduates who are giving their MD and MS exams, and especially the DNP exams as well, because it forms a major chunk. So before we wind up, I would like to make 2 announcements. The first one is regarding the physical iFocus, which is coming up in June from 9 to 16, and this time it's going to be held in Hyderabad. So all of you guys hurry up, because the registration is limited to 300 candidates, and the concessional yearly word registration also closes very soon. So you can find the link down. You can very well register with this link. All right, and so the second announcement is we again meet on the 6th of March for the International Masterclass on the medical and surgical treatment of thyroid eye disease, an update by Dr. Dawn Kikawa. So that's all for today. Thank you very much for logging in, and have a great weekend. Thanks.
Thank you so much.
Thank you so much, sir.